I think over the last 20 years, more or less, AML has been stagnant about treatment. But now, over the last 6 months, you have new drugs being approved for the treatment of these patients. So certainly what we find now is that the AML treatment has moved from being sort of a generalized treatment, like all the drugs for everybody, in a more personalized based care. So we have drugs now, and we understand that the AML is a disease, and we know the foundation of AML very well now with all the molecular data. So based on the molecular data, we can actually treat the patient in the best possible way, and the patients can live longer, and the leukemia can be in remission for longer. So what we have here at ASH is we have the new FLT3 inhibitors in AML. So we have the midostaurin, which has been recently approved by NICE in the UK, and of course we have new FLT3 inhibitors coming, like gilteritinib or crenolanib, AAC220 or quizartinib, and of course there will be a comparison between these FLT3 inhibitors to see the benefits to the patients. But also we have other small molecules like venetoclax, which is a BCL2 inhibitor, and has shown to be effective in patients who do not have intensive chemotherapy and not able or fit to have intensive chemotherapy. And it is in combination with drugs like low-dose cytarabine or azacitidine, and this induces quite a significant range of complete remissions and prolonged survival. But also we have the monoclonal antibodies like Mylotarg, which in combination with chemotherapy, again, it has prolonged survival for the patients with AML, and it has induced a much more prolonged leukemia-free survival for these patients. So we have also another drug called CPX-351, which is one of the most recent additions within NICE, that's directly against specific types of leukemia, like the secondary leukemias. And there are patients who have secondary leukemias. These are very, very difficult leukemias to treat. And certainly with the new drug, the CPX-351, there is hope for a higher remission rate and more prolonged survival. But also for patients who are very fit, by giving the CPX-351, they can actually go for an allogeneic stem cell transplant, whereas with the standard chemotherapy that we had all this time, this was not really guaranteed.